Good morning, everyone, and thank you for joining us today for Dr. Matthew Galsky on immune checkpoint blockades. Dr. Galsky is a professor of oncology and neurology at the Mount Sinai Hospital. He received his medical degree from Tufts University School of Medicine and completed his residency in internal medicine at Beth Deaconess Medical Center. After residency, Dr. Galsky pursued a fellowship in medical oncology at Memorial Sloan Kettering Cancer Center, where he served as chief fellow. Dr. Galsky specializes in the care of patients with genitourinary malignancies. His research is focused on the clinical development of novel therapies for bladder cancer, dissecting the clinical basis for the heterogeneity of patient outcomes, and understanding the disconnect of the efficacy and effectiveness of available treatments. His current research extends these efforts to team-based approaches focused on novel bladder cancer therapies, with a particular focus on immunotherapeutic approaches. He currently serves as the director of the Genitourinary Medical Oncology Center at Tisch Cancer Institute. Please join me in welcoming Dr. Galsky.
Thank you, and thanks for inviting me to speak today. So, I usually speak about bladder cancer, and in the interest of not thoroughly boring you by telling you probably more than you want to know about bladder cancer, I took a little bit of a broader approach, and I'm going to speak about immune checkpoint blockade in general. Here are my disclosures. So I probably don't have to outline the scope of the problem to this group, but cancer continues to be a very big problem. In 2014, 580,000 patients died in the United States of cancer. And to put that into a little bit of perspective, the population of Atlanta is 460,000, and the population of Albuquerque, New Mexico is 560,000. Also, in 2014, cancer surpassed heart disease as the leading cause of death in 22 states in the United States. So I'm not going to focus on bladder cancer, but I did want to start with a case from my clinic to provide a little bit of clinical context here. And these are scans from a patient who I met in July of 2014. This is a man, a retired physician actually, who was in his 80s when he came to see me. And he had been diagnosed with bladder cancer about 6 months earlier, metastatic to lymph nodes, was treated with standard chemotherapy in an outside hospital, and had very severe toxicity even in the context of what we see with traditional chemotherapy. Ended up with a prolonged intensive care unit admission. And ultimately recovered from that, came to see me, and by that time was having progressive disease. You can see metastatic disease to the nodes here, and enrolled on a clinical trial with PD1 antibody. At the time, there were no standard treatments available for patients with metastatic bladder cancer who progress on first-line chemotherapy. And here are his scans 2 months ago. So 2 years later, he's had a complete response. He remains on treatment, getting treated once every 3 weeks. That's how this drug is administered, really tolerating treatment quite well. And while this is a little bit of an extreme example, we see this with this class of therapies, and this is really quite different than what we've seen with cytotoxic chemotherapy in the past. So today what I'm going to do is talk a little bit about what immune checkpoint blockade is, discuss the clinical experience so far, talk a bit about the side effects and how they're managed, talk a little bit about why some patients respond to treatment and why some patients don't, and then how can we increase the proportion of patients who do experience clinical benefit like the patient that I showed. So immune checkpoint blockade is a relatively recent story, but like most stories in medicine, this has roots that date back much further. So this is William Coley here. And William Coley was a surgeon. You can see he was a surgeon to the hospital for ruptured and crippled. So if we've done nothing better in the past 100 years, we'd probably learn to name hospitals a bit better. And Coley made a really interesting observation. And so he was a surgeon, cared for patients with cancer, but a lot of the patients he cared for had these fungating tumors that were growing externally. And he made the observation that patients with cancer who developed infections, infected tumors, oftentimes did better and sometimes even had regression of their tumors. And so he decided that if that was the case, maybe he should infect patients' tumors and see if he could reproduce those results. So he developed something which ultimately became known as Coley's toxins. And this was killed strep and serratia, and he used to apply this to patients' tumors. And in this paper published in 1893, and I would recommend anyone interested in this topic at all to read this. It's a fascinating read, just in terms of how science was done then and how manuscripts were written. So he writes this paper, and it consists of a case series, including patients that he had witnessed in the clinic who had become infected, in addition to 10 patients that he treated with this preparation. And this manuscript is complete with photographs. And you can see here, he describes this patient with a round-celled sarcoma of the neck cured by erysipelas, and the picture was taken 7 years after the initial diagnosis. So this treatment persisted for several years, and you can find evidence of this. So here's a clipping from the New York Times in 1908. And it describes 2 patients in St. Louis who were treated with a similar approach and had a favorable outcome. And the New York Times said, Dr. Coley has used the cure for 15 years, treated 430 cases, probably 150 sure cures. So pretty incredible here. And it wasn't until decades later, with advances in understanding of immunobiology, that there is some mechanistic basis for probably what was happening here. And probably what was happening was that these bacteria produced pathogen-associated molecular patterns, which caused maturation and activation of tumor antigen-loaded dendritic cells, which would then cross-present antigen to T cells, leading to T cell activation, ultimately T cell infiltrating tumors and tumor destruction. And so Coley's approach fell out of favor, but there was a core group of immunologists and immunotherapists who really continued to explore the immune system as a treatment for cancer, really fueled by additional advances in understanding immunobiology. And really, this had to do with 3 characteristics of the immune system that made it really a perfect cancer treatment. So one is the specificity of the immune system, and of course, compared to what we achieve with cytotoxic chemotherapy, which is quite a narrow therapeutic index, and the collateral damage associated with the side effects that we see, the immune system is quite specific. The immune system has memory. So instead of giving treatment until patients have progression of their cancer, giving a treatment that could be administered for just a fixed period of time but produce a durable benefit is of course attractive. And finally, the immune system has memory, so maybe responses would last longer than what we achieve with standard treatment. So there were a number of approaches exploring cancer immunotherapy over the years, and in solid tumors, pretty modest results. Some successes with treatments like high-dose IL-2 with other cytokines, but in general, the successes were few and far between. But immunotherapists kept coming back to this idea, and one of the reasons they kept coming back was this observation here, which I think is one of these observations in medicine that's really simple, but really quite elegant and important at the same time. So here's 2 photomicrographs of patients with bladder cancer. And the H&E sections, you can see bladder cancer. They look pretty similar, standard bladder cancer. But there's something very different about these tumors, and you really don't notice that until you stain with CD8. And you can see that this tumor is full of immune cells. And this tumor really has few CD8 positive T cells, what has been come to known as an immune desert of sort. So clearly there is the development of an anti-tumor immune response here, and this really speaks to the potential utility of the immune system, even despite the lack of success in the clinic. And so the next breakthrough really relied on further understanding of basics of immunobiology, and this had to do with regulation of T cell responses. So we were taught in the past, and I think I was taught this when I was in medical school, that for a T cell to become activated, it requires presentation of antigen in the context of MHC to the T cell receptor. But it turns out that that signal alone is insufficient, and that you really need a second signal here. And you need B7 family molecules to bind to CD28 to cause T cell activation when antigen is presented. When T cells are activated, though, there's an upregulation of other molecules to the cell surface, negative co-stimulatory molecules, including CTLA4. And CTLA4 actually binds B7 family molecules with higher affinity. And when this interaction takes place, this attenuates the T cell response. And teleologically, this is probably in place to control the amplitude and duration of the immune system. Otherwise, there would be no way to turn off the immune system. So Jim Allison, who won the Lasker Award for this, reasoned, and it sounds sort of obvious at the time, at least based on how I'm setting this up, but a completely revolutionary idea at the time. He reasoned that if this is the case, maybe we could block CTLA4 and cause proliferation of T cells, and that would have anti-tumor effects. So developed antibodies to bind to CTLA4, favoring the interaction between CD28 and B7 family molecules, and tried this in murine models. And this is the landmark paper published in Science in 1996, where he takes syngeneic animals, gives them a blocking antibody to CTLA4, and you can see that the animals treated with vehicle have rapid progression of their tumors, whereas those treated with CTLA4 blockade have significant tumor growth inhibition. And in tumors in mice who reject tumors with this approach, when you try and challenge them again with tumor, they don't form tumors, suggesting that some immune memory is indeed happening here. So this approach is taken into the clinic, and it's tried first in melanoma. Melanoma is sort of the prototype cancer where immunotherapies have been tried in the past. And this is the original phase 1 study with the CTLA4 antibody ipilimumab. 88 patients are enrolled with metastatic melanoma, and you can see 2 out of 88 patients respond, so not a great response rate. And I should clarify what I mean by objective response and response rate. So when we develop drugs in oncology, one of the immediate measures of outcome is just looking at scans and seeing if tumors shrink. And if we're going to do that, we need to do that in a reproducible way. So there are criteria used to assign whether or not a tumor has shrunken to the point where it's called a partial response, or a complete response is complete disappearance of tumor on radiographic imaging. So 2 patients respond. These responses are pretty long for what was seen with prior therapies for metastatic melanoma, but of course the response proportions are low. And there's some considerable toxicity here, and I'm going to speak a little bit more about that later. So this treatment could have easily been rejected at the time. And here's where the observations of clinical investigators became very important. And this really speaks to the importance of team science. So clinical investigators who were developing anti-CTLA4 antibodies in the clinic noticed that the kinetics of response that they were seeing were completely different than what we saw with chemotherapy in the past. And here's 4 examples here. And what these figures show are days from the start of treatment. And on the y-axis is % change in tumor size from baseline. So 0, so if the line goes down, the tumor shrank. And these little triangles here are the days that the patients received treatment with ipilimumab. So you can see this patient here has a response that's pretty typical of what we see with cytotoxic chemotherapy when patients do respond. They get treatment, a short time later we repeat scans and the tumor shrinking. But you can see in B, C, and D, what happens is that patients are getting this treatment and the tumor's growing. And in this patient, there was even new tumors detected on their first restaging evaluation. This is 2 months after starting treatment. But the patients were continued to be observed. And if you follow them out for longer, the tumors start to shrink. And this can happen many, many months after initiation of treatment. So the clinical investigators argued that this drug shouldn't be discarded, but really the endpoints should be changed. We should really be focused on survival outcomes with these treatments. Ipilimumab enters phase 3 testing, is shown to improve survival in patients with metastatic melanoma compared to chemotherapy, and is approved by the FDA. And it's become a very important treatment, not because it works in everyone, because unfortunately it doesn't, but when responses occur with this medicine, they tend to be quite durable. So here's a pooled analysis from several clinical trials exploring ipilimumab, looking at long-term outcomes, and you can see a tail on the curve here, out many years. We just didn't see that with treatments for advanced cancer in the past. The other unique feature of this particular treatment is that it's given in 4 infusions and then stopped, unlike the treatments that we give typically, which continue until patients progress, like cytotoxic chemotherapy. So ipilimumab, CTLA4 antibodies are then tried in a bunch of other cancers, and really nothing else responds to treatment with ipilimumab. And in parallel with this, other immune checkpoints are recognized, and these start to be explored. And there's another really important but simple clinical observation which has really changed the way that we think about some of these other immune checkpoints, and that's highlighted on this slide here. I told you already that some tumors are infiltrated with T cells, and one of the immune checkpoints that was discovered next was PD1. This is a molecule that's also upregulated on the surface of T cells upon activation. And the ligand for PD1 is PD-L1, previously known as B7H1. So when investigators started staining specimens for PD-L1, what they recognized was wherever you saw CD8 positive T cells, you generally saw PD-L1 in the neighborhood. And this led to this concept of adaptive immune resistance. So what the hypothesis is here is that antigens presented to T cells by either tumor or antigen-presenting cells. And that leads to activation of T cells and release of gamma interferon. At the same time, these activated T cells upregulate PD1 on their surface, and interferon causes inducible expression of the ligand PD-L1 either on the tumors themselves or in the tumor microenvironment, leading to then downregulation of the immune response. And this probably explains why you have these tumors which are full of immune cells, but there's still tumor there. The immune cells haven't eradicated that tumor. They're just sitting there waiting to attack, but can't because of this mechanism of resistance. So of course, what becomes logical is maybe we could block this interaction too. And antibodies have now been developed against either the receptor, PD1 antibodies, or the ligand, PD-L1 antibodies. And these entered the clinic, and pretty rapidly it was determined that these drugs are quite different than CTLA4 blockade, and really quite different than drugs that we've seen in the past. Here are 2 studies published in the same journal, same issue of the New England Journal of Medicine in 2012, one with a PD1 antibody, one with a PD-L1 antibody, really both studies showing the same thing, which is that instead of responses just in melanoma, we start to see responses in other tumor types like kidney cancer and non-small cell lung cancer. And really, it was quite a surprise that non-small cell lung cancer would be an immune responsive disease, a disease that's so genomically complex. But patients with non-small cell lung cancer responded to this drug, and the response rates, the objective response rates with these medicines were much higher than what was seen with CTLA4 blockade. The other important finding, similar to CTLA4 blockade, was that response durations were quite long. So these are called swimmer's lane plots, and each one of these represents a patient, and this is the weeks since treatment initiation. And if there's a dark arrow at the end of this lane, it means that at the time that the data set was locked, the patient was still responding to treatment. So on this phase 1 trial, when the data were reported, the majority of patients who were responding to treatment were still responding. The other unique feature with this medicine, similar to what was seen with CTLA4 blockade, was that responses tended to last even when the medicine was stopped. Now, the development of these drugs has been a little bit different than CTLA4 blockade, and for a variety of reasons, instead of just giving a fixed number of infusions, these medicines have generally been continued for longer. but some patients have to discontinue treatment because of side effects. And you can see here the blue indicates patients when they're on treatment. The red indicates after they've come off treatment, with again the dark arrows representing ongoing responses. And you can see that even after stopping treatment, many patients have ongoing responses for weeks to months. And we certainly see this in the clinic as well. So PD1 and PD-L1 antibodies have now been explored in a huge number of different solid tumors. And across really every solid tumor that's been studied so far, there's been a response rate of about 15 to 40%. And this includes kidney cancer, bladder cancer, head and neck cancer, triple-negative breast cancer, esophageal cancer, et cetera. So really a broad spectrum of activity with these drugs, and a little bit of the antithesis of what we thought was the direction of medical oncology, just five years ago, where we thought that not even every tumor type, but every individual patient was going to need a highly unique treatment. And really we're seeing one medicine or one class of medicines with just this broad level of activity. There are 3 PD1 and PD-L1 antibodies now approved by the FDA. Pembrolizumab is an anti-PD1 antibody made by Merck, and this is the first, was approved in September of 2014 in melanoma, also approved in lung cancer and metastatic head and neck cancer. And I should point out that all these approvals are for patients in general who've already had standard chemotherapy and then had progression of their cancer, just the nature of how drugs are developed in oncology. Nivolumab, an anti-PD1 antibody from BMS, is approved for those cancers, but also for kidney cancer and Hodgkin's disease. And atezolizumab is the first anti-PD-L1 antibody approved, and this was approved just a few months ago and became the first drug approved for the treatment of metastatic bladder cancer in 30 years. So instead of going through the individual data from all these various solid tumors in detail, which obviously there's not time to do, I just want to highlight some general characteristics that have been observed across the clinical development of these drugs. So the good, when responses occur with these medicines, they tend to be quite long. And they occur pretty quickly as well, and I'm going to speak to that a little bit more. And in general, these medicines are really well tolerated compared to standard chemotherapy. And here's the swimmer's lane plots. Again, this is from bladder cancer, where we have a little bit more follow-up on this study compared to the other slide that I showed. And so you can see these yellow dots here indicate the time of first response. And so the median time to respond to these medicines is about 2 months, which again, quite different than we thought would occur with an immune therapy. We thought that it would take a long time to respond, sort of what we saw with CTLA4 blockade. But responses, when they occur, tend to be quite rapid, and they tend to be quite durable as well. So now we have data going out 1 year, soon we'll have data going out 2 years, and patients often ask me when they're responding to these medicines, how long will this response last? And the honest answer is that we don't know yet. We have patients who are still treated on the initial trial, still responding to treatment. Most of the median response durations have not been reached. So we don't know, and this is an evolving story. There's a downside, and the major downside is that these treatments work, as I showed you, in a small proportion of patients, and these treatments are quite expensive, as you might imagine. And then there's the ugly, which is the side effects. And while severe side effects don't occur in the majority of patients, there are serious side effects in a small subset, and you might have encountered some of these patients in your clinics or in the hospital. So here's the side effects from patients with metastatic bladder cancer treated with atezolizumab. And when we do clinical trials and we capture side effect data, we use definitions of adverse events that are developed by the National Cancer Institute. There's a dictionary of terms, and that dictionary of terms also grades the severity of side effects according to specific definitions. So grade 1 is the least severe side effect, grade 4 is the most severe side effect, and grade 5 is a side effect that leads to death. So you can see the majority of patients treated with this drug in this study had very few grade 3 and 4 side effects. The rates of all grade side effects were a bit higher, although each individual side effect is on the relatively low side. The side effects that we get concerned about the most are those that are immune-related, or those that are related to this mechanism of action. And these really mimic autoimmune events, and there are a number that can happen. And I'm going to speak about that a little bit more, but I just wanted to highlight that the likelihood of developing an immune-related side effect is on the low side. The problem is that really anything can happen. And you name an autoimmune side effect, or you name an autoimmune disease, and we've seen the equivalent of it as a side effect with these medications. And this really spans every organ system and every degree of severity as well. In addition to that heterogeneity, there's also heterogeneity in the onset of side effects. So this is a study of 474 patients with melanoma who were treated with a PD1 antibody. And you can see skin immune side effects, colitis, liver toxicity, pulmonary toxicity, endocrine toxicity, and renal toxicity. And the time of onset, the median time of onset of these side effects tends to be about 2 to 3 months. But you can see here that it's completely across the board. And we've had patients develop colitis a year and a half after starting treatment, whereas they had done well with really no side effects prior to that time. The most common immune-related side effects with these medicines are skin-related, and usually it's just a mild rash that we don't treat at all. Sometimes topical steroids, rarely systemic steroids are required. Probably the most feared side effect of CTLA4 blockade is colitis, and this happens in up to 30% of patients treated with CTLA4 blockade. It's a bit lower with PD1 and PD-L1 blockade, probably at most about 10%. And this really presents like inflammatory bowel disease-associated colitis. Oftentimes there's an increased frequency of stools rather than diarrhea, cramping, increased frequency of stools, but we do see frank diarrhea. Sometimes we see bloody diarrhea. There are specific management algorithms that have been developed over the years, given how severe these side effects can be. And typically for a very mild increase in stool frequency, we just treat with Imodium. But for more frequent stools, we have a low threshold to initiate steroids. And steroids are effective in resolving this side effect in the majority of patients. And when the diarrhea really gets severe, it does warrant hospitalization. For patients who are refractory to steroids, at times we do need to treat with infliximab. When steroids are started and the side effects resolve, generally a very slow steroid taper is warranted, and at least over a month. And depending on the severity of the side effect, there is a decent amount of experience with restarting these treatments. So when they're very severe, when the side effects are very severe, we don't restart. But for mild side effects, which resolve with steroids, and once patients are off steroids, we do restart these medicines, and very frequently the side effect won't recur. Endocrinopathies can occur with PD1 and PD-L1 blockade. A picture like autoimmune thyroiditis is relatively common. We check TFTs with each treatment. Typically what we'll see is a transient hyperthyroidism followed by hypothyroidism, and patients require replacement therapy. And then hypophysitis we see more commonly with CTLA4 blockade, pretty uncommon with PD1 and PD-L1 blockade. As opposed to colitis, and some of the other side effects, the use of high-dose steroids for the endocrinopathies, particularly for hypophysitis, is a bit controversial, as this side effect probably isn't reversible, and patients do require maintenance steroids, but whether or not high-dose steroids help decrease the duration or the severity of the adverse event is really questionable. There is actually a mouse model of CTLA4 blockade-induced hypophysitis, and it probably has something to do with pituitary expression of CTLA4. Pneumonitis is probably the most feared complication of PD1 and PD-L1 blockade, And the frequency of this occurring is on the low side, but can be fatal and has been fatal, and that's why we take it quite seriously. And you can see here that really there can be various radiographic presentations of pneumonitis. Oftentimes we'll catch this when it's asymptomatic because we're scanning these patients relatively frequently anyway. For radiographic changes in the absence of symptoms, we just monitor patients. But for patients with mild symptoms, again, a low threshold to start steroids, and we have a relatively low threshold to hospitalize patients and work them up further when there's any suggestion that the course is headed in the wrong direction. So there's been a lot of work in terms of developing management algorithms for these side effects because this is relatively new and because the side effects are uncommon but can be fatal. Some of you have been referred patients from me, from my colleagues to see with these side effects, and I just wanted to highlight this section in this paper because this is buried in the oncologic literature, but I think it's helpful for you to know what we're reading. And this section has to do with organ specialist referral, why, when, and how. And it says that the current experience of managing immunotherapy toxicities is low and requires expertise. Organ specialist or internist referral is needed for mainly two reasons: for oncologists to learn proper management of specific disimmune toxicities, but also for organ specialists to increase their knowledge about these new drug-mediated toxicities, creating a virtuous circle for patient management. So very important, and it is important to have organ specialists who have a specific interest and expertise in these side effects to create this circle of patient management. I also think it's probably been a little bit underexplored the value of studying patients who develop these side effects in terms of improving insights into autoimmune disease. So perhaps the most important slide in the take-home points here. Immune-related colitis, pneumonitis, and some other immune-related adverse events have proven fatal without proper recognition and intervention. So our dogma, and really we drill this into patients, is early recognition and reporting, low level of suspicion that anything unusual is probably related to the drug, and early use of steroids if there's any concern about the course. So there are a couple of practical management issues that come up regarding these side effects. And of course, one is we're giving a treatment that's supposed to stimulate an immune response, and then we're giving steroids. It sounds sort of counterintuitive, and maybe we should have a higher threshold to start steroids. And in fact, this has been explored in several clinical trials in terms of whether or not initiation of steroids has any effect, any counterproductive effect in anti-tumor immune responses, and that has not proven to be the case. So even though theoretically we still proceed with a little bit of caution, practically there is no evidence that giving steroids is going to mitigate the response to treatment. The other practical issue that comes up, and it's come up more and more commonly because now we're looking for this, is can these patients be safely treated if they have a history of autoimmune disease? Patients with psoriasis, thyroid disease, inflammatory bowel disease, rheumatoid arthritis, all these patients were excluded from the clinical trials that have been done. And so it's now only that these drugs are commercially approved where we're getting more experience. And the real answer to this question is that we don't know. There's not enough experience yet. There's been one case series published just this year with CTLA4 blockade, looking at the course of patients with baseline autoimmune disease who received CTLA4 blockade. And you can see it's about 30 patients, a smattering of autoimmune conditions, a few patients with inflammatory bowel disease, rheumatoid arthritis, sarcoidosis. Approximately half of these patients did experience worsening of their autoimmune disease with treatment that was managed with standard medical management. And a large number of these patients responded to treatment as well. So it does appear to be safe, but certainly we proceed with caution. And it depends on the severity of the underlying disease as well and whether or not it's been active or quiescent. So I've told you about a class of drugs that produces pretty robust benefits in a small proportion of patients. And so this would be the perfect argument for a precision medicine approach, right? if there's 20% of patients who are benefiting, then instead of treating patients like this, like we do now, if we can identify who these patients are, we should treat them with this approach and treat other patients with something else. So there's really been an intense search for predictive biomarkers of benefit from these drugs. And there was a lot of excitement in the initial trials that simply staining for PD-L1 might be the answer here. And here you see the phase 1 trial with nivolumab, the PD1 antibody. And you can see here that they simply stained archival tumor tissue for PD-L1. And in patients who had no PD-L1 staining, 0 out of 18 patients responded to treatment, whereas if you had PD-L1 staining, the response rate was 13 out of 31. So that caused a lot of enthusiasm. But what commonly happens with biomarkers, when tests were moved from the test set situation to validation sets to larger data sets, this distinction became a little bit less apparent. So this is the experience in bladder cancer. You can see in the phase 1 study, the response rate was 50% if you had PD-L1 expression and 18% if you didn't. But if you move to the phase 2 studies, this distinction gets much smaller. And there are a number of reasons for this, one of which is that PD-L1 is probably a very dynamic protein as compared to something like testing for a somatic mutation, which is either going to be present or absent. So that's one problem. Another problem is that we're looking at archival tumor tissue, which might have been taken out months to years earlier, and expecting that to predict an event right now. So that's been problematic. The other thing that's been problematic is that each company that's developing a PD1 or PD-L1 antibody is using a different test. They're using a different companion diagnostic based on a different antibody, using a different cut point, and even looking at a different cellular compartment. So atezolizumab, the PD-L1 antibody, the test looks at PD-L1 expression in tumor-infiltrating immune cells, whereas the Merck antibody looks at staining in both tumor cells and tumor-inflammatory cells. The BMS test looks only at tumor cells. This is a bit of a mess. There's been one registration limited to PD-L1 expressing patients so far, and that's the use of pembrolizumab in lung cancer. The rest of the labels for these drugs don't require testing, and we don't routinely do testing. I should actually point out that one of the other reasons that we don't do testing is because the best drugs that we had in bladder cancer before had a response rate of about 10%, and the responses lasted just a couple months. So even with a negative test, this treatment is still better than what we had before. There haven't been predictive biomarkers that have yet made a difference in the clinic, but there's been mechanistic insights established with each biomarker that's been explored. And you'll remember that we talked about before the fact that some tumors have infiltration of T cells, and those tumors were the same tumors that seem to have PD-L1 expression. So maybe it's actually the presence of the T cells in the tumor microenvironment that should be the predictive biomarker. And in fact, in every study that's looked at this so far, if you have a tumor that's infiltrated with T cells, you have a higher likelihood of responding to these medications. And so that leads to the hypothesis that perhaps instead of looking for the looking at expression of PD-L1 itself, we should be really trying to understand what's recruiting these T cells into the microenvironment. What are the antigens here? Because maybe then we can select patients for treatment. And so there's been an intense search, and really patients responding to treatment now can fall in one of three main buckets. One is that some tumors express viral oncoproteins. Head and neck cancer is one example of this. And you can see here that with the experience of PD1 blockade in patients with metastatic head and neck cancer, patients with HPV-positive disease tend to have a higher response rate. A second are tumors that express PD-L1 under oncogenic regulation, and the prototype illness for this is Hodgkin's disease. So it turns out that PD-L1 is a target for amplification of 9p24, which is a recurrent genetic alteration in Hodgkin's disease. And you can see here that when PD1 blockade was explored in refractory Hodgkin's disease, the the response rate was 87%, so higher than any other tumor that this has been tested in so far. I think probably the most interesting bucket here, and the one that I'm just going to spend a few more minutes discussing, is this issue of high mutational burden. So for tumors to mount an immune response, they need to have an antigen present. And probably the best antigens are those that look least like self. We also know that tumor genomes are complex. They harbor multiple mutations. So it's not a big leap to think that maybe it's the mutations that are, maybe it's the proteins that are encoded by these mutations, which are the best tumor antigens. They probably look the least like self. It also turns out that a rate-limiting step in antigen presentation is the affinity of binding peptides to MHC, and that affinity can be predicted based on computational approaches. So this leads to a few implications. One of which is perhaps the more mutations you have, the more likely you are to have an antigen that's recognized as foreign by the immune system. And these antigens are commonly called neoantigens, these mutation-derived tumor antigens. The other implication is that because this depends on the affinity of binding to MHC, which can be predicted based on peptide sequences, the potential neoantigens could probably be predicted computationally. And the third implication is that instead of shared tumor antigens across different patients, perhaps the best antigens are actually individual to each patient. And so this concept has been tested, and it's been tested both indirectly and more directly. The first evidence supporting this observation is simply looking at the mutational burden of cancers. So here we see several different types of cancers that have been profiled using whole exome sequencing and the number of mutations per megabase. And you simply look at what falls on the end of the spectrum here, the highest mutational burdens: melanoma, sound familiar, the prototype illness for immune-related therapies; lung cancer, another disease that has been highly responsive to immune checkpoint blockade. So some evidence that this indeed does hold true. There's been some direct evidence as well, or more direct evidence. 2 landmark studies published around the same time. In fact, one published by a Mount Sinai alum, and I'm actually not going to talk about that study because it involves CTLA4 blockade. But this study by Rizvi et al. Looked at 2 cohorts of patients who were treated with PD1 blockade with non-small cell lung cancer. And what he did was whole exome sequencing of all these patients' tumors and simply look, if you had a higher number of mutations, did you do better with this approach? And even with this small sample size, pretty evident that patients with a high mutational burden do better. They next calculated the predicted neoantigen burden using these computational pipelines that can predict candidate neoantigens. You can see the more candidate neoantigens you have, the higher likelihood you have to have a durable clinical benefit and also an improved progression-free survival. So mutational burden probably translates to neoantigen burden, and this matters in terms of response to these drugs. And this is, I think, really such an interesting observation because it's completely the opposite of what we thought about tumors. When tumors started to be sequenced, particularly pancreatic cancer, colon cancer, we saw these very complex tumor genomes and really created a lot of pessimism about how are we going to treat these. And in fact, the more mutations you have, the more mutationally complex your tumor is. It turns out that's actually better. So you can take this a step further, and you can say that if mutations matter, then maybe we could identify tumors that have a lot of mutations that are the best candidates for this approach. And one candidate tumor would be those with deficiencies or mutations in DNA mismatch repair. So we already said that tumors are mutationally complex. Lots of somatic mutations. Sometimes these somatic mutations occur in the very machinery that repairs DNA. And if that happens, then you can imagine that those tumors can't repair DNA. They start to accumulate all of these mutations. And so this occurs in mismatch repair deficient colon cancer. These same genes are altered at the germline level in Lynch syndrome, but occur somatically as well in genes like MLH1, MSH2. So when these genes are mutated, these tumors can't repair DNA damage repair. And now when we take another look at this mutational burden across different solid tumors, you see here's microsatellite stable colon cancer with about 50 mutations per specimen. And here's mismatch repair deficient colorectal cancer, completely off the charts. These mutations actually occur at lower frequency in some other cancers as well. So that led to the design of this phase 2 trial, which enrolled patients with colon cancer into 2 cohorts, those who were deficient in mismatch repair, those who were proficient, and then there was a third cohort of patients who had mismatch repair defects but with other solid tumors. And to cut to the chase here are the results of this study. In patients with mismatch repair deficient colon cancer, the response rate was 62%, 60% in patients with other cancers, 0% in patients with microsatellite stable colon cancer. So really providing additional proof of this concept. Obviously, we need to increase the proportion of patients who respond to these drugs further, and the field is really focused on combination therapies to achieve this. I'm not going to go through this in detail, but there are a number of combination strategies that are rational and that have entered the clinic. This is a key area of interest for us, both laboratory and in the clinic. The first combination that's really advanced is simply putting these 2 immune checkpoint inhibitors together. These work in different phases of the immune response. CTLA4 is a little bit earlier in the priming phase, PD1 a little bit later in the effector phase. So there is rationale for combination, and this is the experience in melanoma when you combine the drugs. The response to single agent ipilimumab is 19%, 43% with nivolumab, the PD1 antibody, 57% when you combine the drugs. And the combination is now FDA approved for the treatment of melanoma. When you combine these drugs, you do also get a decent increase in the frequency of immune-related adverse events, though, so this treatment is not for everyone, and we need to develop both better and safer combinations. So this is how we used to measure progress in oncology clinical trials. We had drugs that increased survival by a relatively small amount, but provided some clinical benefit. And I hope what I showed you is that now we're starting to measure progress instead of these improvements in medians by the tail on these curves. And ideally, what we'll be seeing in a few years are curves like this based on combination therapies. I just want to make one more point, particularly for the trainees, about timelines. And so science that impacts the clinic in a major way takes a long time. And you can see that CTLA4 was cloned in 1987. The first anti-CTLA4 antibodies entered the clinic a little less than 15 years later, and then ultimately approved by the FDA 11 years after that. And a similar story with PD1 blockade. So this takes patience and persistence. And I'll stop there. Thank you.
Thank you for making this topic say much more accessible than I'd ever thought for a general internist. I wonder, is there some way, perhaps under the selective pressure of first and second line chemotherapies, to make tumors more inflammatory or induce more mutations, that then they would be more responsive to immune checkpoint blockade?
Absolutely. So it's a great point. And that has been tested looking at mutational burden and the types of mutations both pre and post chemotherapy. There is an increase in mutational burden in those limited studies that have been done. Whether or not that translates into benefit, we're not entirely sure yet. There is probably, so a lot of the combinations that are being explored are trying to exploit what you say, turning these immune deserts into immune-infiltrated tumors. And it turns out that employing just the same chemotherapies that we use to treat the disease of interest might not be the way to do that. There are probably certain chemotherapies that cause immunogenic cell death that release these danger-associated molecular patterns that might not be the same as we would use in those diseases otherwise, so that requires a lot more work.
So the other variable here is polymorphisms in the individual's CTLA4 and PD-L1 or PD1 as well. I mean, we've shown that if you block CTLA4, depending on very frequently occurring polymorphisms, that you get a different immune response and different outcomes long-term in transplant. So surely this is playing an effect in the variability between individuals here.
Absolutely, and germline genetics have been really underexplored in these trials so far, in part maybe based on sample sizes and just accumulating enough data and enough events.
Has anyone begun to look for genetic markers that predict the complications?
That's a great question. So not that I know of.
Again, maybe.
Sure. And certainly genetic polymorphisms in immune checkpoints have been associated with an increased likelihood of developing autoimmune disease, in the absence of these treatments.
Yeah, exactly. Okay, great. Thank you very much.